I think we're up and going on about page 528 where I have us in the respiratory chapter. We're going to try to knock this chapter out today and as skimming across it as much as we probably will. We'll probably be taking our next test next week because I'll need that week before Thanksgiving and 2 weeks after to knock out the final, which I want to spend more time with it. So on 528, we just had gone over the conducting zone, I believe it was, and the respiratory zone. And we had decided that conducting zone is mouth, nose, pharynx, larynx, trachea, primary bronchi, and successive branches. And additional to these structures, what else did it do? It warmed, it moistened, and it filtered. And then we had discussed cigarette smoking, which we're going to talk a little bit more about that as we get in this chapter. But I will say this: one cigarette will take 10 minutes off your life. A pack will take 3 hours and 33 minutes. I think that's kind of where we finished up, wasn't it? Or did we say that the other day? I can't remember from class to class. So, but your lungs have tremendous ability to regenerate, to come back to normal if no damage occurs. You know, if somebody smokes for 10 years and quits, it'll take 10 years, but your lungs have tremendous ability to return to normal if they have not been damaged in that first 10 years. And damage would be some mutation, some genetic mess up because of the carcinogens in the smoke. So that can happen. People can quit 20 years ago and then get cancer 30 years out. What was it from? It was from the damage way back there. And all cancers are very similar. You know, my dad deals with different kinds of skin cancer. And that's because when he's a kid, outdoors all the time, they didn't have sunscreen back then. He wears it liberally now, but it's not, he's not protecting, well, he's protecting against skin cancer now, but he's fighting skin cancer that was caused when he was a kid. And that's when it shows up, it catches up with us somewhere down the line usually. All right, moving on from there to into physical aspects of ventilation. Over on page 530, they do some different pressures and some transpulmonary and intrapulmonary and intraalveolar pressures. And basically when we get down to this, we're talking about what it takes to breathe here. And we're seeing pressure differences inside and outside. So in the process of inhalation, inhalation is an active process. It requires muscle contraction. It requires the ribs to go up. It requires the diaphragm to go down. And that's a muscle contraction, so it's going to take energy to inhale. And what we do when we spread the ribs up and we take the diaphragm down is we create a larger capacity in your thoracic area. And the atmospheric pressure in that area now is less than atmospheric pressure at 760 mercury. That's millimeters of mercury. Inside, you'll be about 763, something like that, or excuse me, 756. I'm a little bit high there. 756, and outside is 760. So air rushes from outside to inside. So we're negative pressure breathers. We don't, it seems like, it may even feel like that we suck air in. But as we change that air pressure difference, air is rushing in to equilibrate the air pressures inside and out. But inspiration or inhalation is an active process. Exhalation is a passive process. All you have to do is relax the muscles involved in the inhalation process. Diaphragm goes back, ribs collapse down, and we increase or decrease the size, which increases the pressure. And now we're at 763, and we force air back out to here. And so expiration, exhalation is a better name because expiration we think we may be dying. It is a passive process. So they go through all these different, there's got to be different pressures in there just to maintain the lungs sticking to the cavity walls. There's always an internal pressure into the lungs called residual volume that keeps the lungs inflated. If those lungs ever collapse, it's difficult to get them open again. Although it's possible, it is still a difficult problem. And they talk about all that on a 530. And they go through the different pressures across the wall of the lung. This pressure difference across the wall of the lungs called transpulmonary pressure or transmural pressure, which is the difference between intrapulmonary pressure and intrapleural pressure. Because the pressure within the lungs, intrapulmonary, is greater than outside the lungs, intrapleural, the difference in pressure, transpulmonary, keeps the lungs against the chest wall. We keep them forced up against the chest wall. Boyle's law, pressure of a given quantity of gas is inversely proportional to its volume. The pressure of a given quantity of gas is inversely proportional to its volume. There's Boyle's law. If you've had chemistry, you've heard of this before. And you have had chemistry, right? Everybody? Good. Physical properties of lungs. The lungs have stretchability. They have the ability to expand, so they must have compliance. That's the term they're using here. And since they have stretchability, another name for that would be elasticity. And the tendency to get smaller is also aided by surface tension forces within the alveoli. So we have surface tension that allows the lungs to decrease in size as air is going out, but not totally collapse. Surface tension provides enough tension that we don't just collapse. So under compliance, distensibility is compliance, the ability to expand and take in more air. That's compliance. Elasticity refers to the tendency of a structure to return to its initial size after being compliant, after being distended. So it gets this big, and then we go back to normal size, and we get this big, and we go back to normal size, but we don't go beyond that normal size. That's when they commence to collapsing. The forces that act to resist distension include elastic resistance, surface tension. That is exerted by fluid in the alveoli, and that is produced by type 2 alveoli, and that's the fluid that prevents total collapse of the lungs. Now on 532, they're going to mention this surfactant, is what it's called, type 2 alveoli. Ability of surfactant to lower surface tension improves as alveoli get smaller during expiration. Surfactant thus prevents the alveoli from collapsing during expiration. Even after a forceful expiration, the alveoli remain open and a residual volume of air remains in the lungs. Since the alveoli do not collapse, less surface tension has to be overcome to inflate them at the next inspiration. So surfactant begins to be produced in late fetal life. You know, the lung is one of the last things that develop on a child. That's our biggest concern in newborns if they're born earlier than we need them to be. If mom goes into premature labor and we can stall premature labor long enough to IV a steroid in her system, there is a particular steroid that we can pump through her, it'll develop those lungs a lot faster within 24 to 36 hours. We need about 24 hours of that in the system. And then it's amazing what the lungs can do at that point. But we've got to stall labor that long to get this in the system. So for the reason that it's produced in late fetal life, premature babies are sometimes born with lungs that lack sufficient surfactant. I thought that was a unique combination of terms they put in there. Say that 3 times real fast, right? And their alveoli are collapsed as a result, and this is called respiratory distress syndrome, which is a very common thing in a lot of preemies, if you will. People with septic shock, extreme fall in blood pressure due to massive vasodilation, may develop a condition called acute respiratory distress syndrome, or ARDS. So there's another one there. Now some of their information they give us on these newborns is pretty interesting, I think. We know a full-term pregnancy runs 38 to 40 weeks, and they range in as much as 37 to 42 weeks. First pregnancies typically go over. The only thing you get into there, every day you go over, they're gaining a certain amount of weight, and so they're getting bigger. That last trimester is just the kid getting massively big. And as they get bigger, when you go over, it's like, holy cow, there's no way they're going to get here now. They're going to slice me wide open to get this baby here. And that's the case a lot of times. But here, 37 to 42 weeks, RDS occurs in about 60% of babies born at less than 28 weeks. 30% of babies born at 28 to 34, and less than 5% of babies born after 34 weeks of gestation. So 34 weeks is kind of a turning point for lung development. If we can get you beyond 34 weeks, we got a good chance of these lungs being at least close enough that they'll start developing what they need to produce.
I had
So,
James at 37 weeks, and they still had the infant surfactant.
yeah. And all the kids, there's a
I
percentage.
had the steroid thing.
You even had the steroids?
Yeah, he was
Wow.
stubborn.
Well, that must be the kid's attitude, huh? I'm sure it takes after the father,
Yeah,
no doubt.
that's what I tell everybody.
Less than 5% of babies born after 34 weeks. So the risk of RDS can be assessed by analysis of amniotic fluid. And mothers can be given exogenous corticosteroids to accelerate maturation of fetus's lungs. So it is amazing what we can do with newborn children, even as early as some of them were born. Some of them come out and fit in the hand, and they survive in the hospital for months, and then they go home. They hit 5 pounds and they go home. But there was a day when those didn't have a chance. But boy, we have some prenatal units out there now that's quite amazing in what they can do. Mechanics of breathing. I'm not going to spend a lot of time on mechanics here because we've already looked at it a little bit with the inhalation and exhalation. But breathing is pulmonary ventilation. I mean, it's scattering oxygen throughout the body as we need it. And of course, it includes inspiration and expiration. I'm glad you could be with us, gentlemen. Now we've got everybody. So they're going to name some muscles involved in this. We've already talked about the passive and active components. Between the bony portions of the ribs are 2 layers of intercostal muscles. We have external and internal intercostals, and then there's also another set of muscles here that's interchondral, and sometimes they're both called together peristernal intercostals. So thoracic muscles involved in deep inspiration. This is like we did in the spirometer the other day. Deep inspiration, all we could gather up to do that vital capacity. Muscles involved in deep inspiration, important is the scalenes, or scalene, pronounce that, you anatomist. Scalenes, maybe. That's the reason I don't teach anatomy. Followed by pectoralis minor, in extreme cases, sternocleidomastoid. Now you're getting serious if you're popping muscles out on your neck, right? Contraction of these muscles elevates the ribs in an anterior-posterior direction. That's almost an oxymoron, isn't it? How you do anterior-posterior at the same time? You're expanding, aren't you? The only way I can figure it out, you're getting bigger. At the same time, the upper rib is stabilized so that the intercostals become more effective, thereby causing air to flow into the lungs, just like we talked about. Now, expiration is passive, decreases the volume. As volume pressure increases inside, we decrease as we push air out. Forced expiration, the internal intercostals would be found in that. When we did the vital capacity the other day, we was trying to, all the air we could get in and all the air we could force out. And we was using everything we could. You can use abdominals, that's talking about internal intercostals, pulling the ribs further down. Just bending over and making yourself smaller causes intestines to push up on the diaphragm even more. And so we was using everything we possibly could to force that last bit of air out. So the abdominal muscles also aid in this forced expiration. They mentioned that in there as well. Then we get into spirometry, which is what we did in lab. In table 16.3, you probably need to pay fairly close attention to that table. And these terms, which I think we did several of these terms in part of the lab. Tidal volumes, normal, 500 milliliters. Vital capacity, I think 3,750, so 3,800 in females and about 4,500 in males. And some of y'all was blowing 55 to 65. Some of you got a lot of hot air in here. Inspiratory reserve volume, of course, the vital capacity is equal to the sum of inspiratory reserve, all you can bring in and all you can force out. They're telling you that as well. Residual volume is always there left behind, and that helps hold the lungs open. And if something's open, it's easier to go into it than trying to crawl into something that's collapsed. And so 1,200 milliliters of air continually stays in there and keeps these lungs open. We have an anatomical dead space. And the point that they want to make here is that every time you inhale a normal breath of 500 milliliters, not all of that is fresh air. There's only about there's 150 milliliters of old air that's in your dead air space, which is open tubes, is what it is. Bronchi, trachea, bronchioles. There's not a plunger that forces all that air out when you exhale. So there's air stuck in there. So every time you breathe in, that 150 goes back in, and 350 new comes in behind it. Every time you breathe back out, we get 350 that probably comes out here. 150 is still stuck in there. So your dead air space is nose, mouth, larynx, trachea, bronchi, and bronchioles. There's your dead air space. None of that area there is an area of exchange. It's an area of travel only. Kind of the conducting zone, if you will. Restrictive and obstructive disorders. This is kind of especially the main part I wanted to get into today for sure. And we've got a long ways to go to knock this out. But restrictive and obstructive disorders, these two, obstructive is typically something that inhibits airflow. Not necessarily permanent. So restrictive would be something that's more permanent, that has caused some type of tissue damage in the lungs. What would asthma be? Obstructive. What would emphysema be? Restrictive, because emphysema is structural damage. They have difficulty exhaling in restrictive, or in emphysema, and asthma could hopefully is temporary. If it's not, it's gonna kill you off. But it's a temporary obstruction, whatever causes those airways to shut down on you. So there's those two. Now there's some other terms in this box on 16.4, table 16.4. Notice anatomical dead space, which we just talked about. You need to know apnea, dyspnea, eunia. Those you definitely need to know for just good quality questions on the test. And the last one at the bottom of that is torr. A torr is a millimeter of mercury. It's just a common term that you may have run across in chemistry. Is it?
Yeah.
But 760 millimeters of mercury is equal to 760 torr, so it's a direct equivalent. They use that a lot in respiration for some reason. All right. Moving on over, so we've covered the emphysema being restrictive. There's some type of lung damage there. Chronic obstructive pulmonary disease. This is just a big term that covers a wide array of problems. And it's almost like the congestive heart failure situation that you get into. If you don't find that in the form at the nursing home, in the folder, you'll find this one. Or you may find them both. And to narrow this down, it's such a wide array. If some doctor, if you come in sick one day and he said, well, you've got COPD, you know, my next thought is it could be so bad that how much time do I have to live? Or we could treat it and you walk away and get over it. It's like, can you narrow that down for me a little bit to tell me if I'm going to live or not? You know, doctors use big terms to escape explanation or lack of knowledge. Think about that. They use big terms to make them sound smart, and they don't have a clue what's the matter with you. But they know it's in the respiratory system. They got it narrowed down to one of many systems. I think you've got a respiratory problem. I knew that, that's why I came to you. So they say, oh, you've got COPD. Oh, how much time do I have to live, doc? Is it that bad? Nah, here's a Z-Pack. Well, I think it'll take care of it. It's crazy. Just teaching you how the cookbook doctors work. That must be here, let's try this. Oh, you're back. Must not have been it. Let's try this. The cookbook approach. So the COPD covers a lot of things, and bronchitis is in that, which is very treatable. Asthma is also treated in that category. In some cases, asthma being classified as a chronic inflammatory disorder is distinguished from COPD in that the obstruction in asthma is largely reversible with inhalers. So one thing they typically throw in COPD is it's something fairly reoccurrent or fairly permanent. But a lot of it's treatable and livable for years and years and years. And some of it gets worse over time, no matter what you do. So, like I said, it's a big term and it's wide open, and a lot of them's explanation or their criteria for it to be, I guess. The inflammatory cells characteristic of COPD are macrophages, neutrophils, cytotoxic T lymphocytes, whereas in asthma there's T lymphocytes, eosinophils, and mast cells. You see a lot of allergic responses in asthma. But if it's so bad and continually reoccurrent, they could actually throw it under the heading of COPD if they wanted to. And some doctors like to do that. So in addition to pulmonary problems directly caused by COPD, other pathological changes may occur, including pneumonia, pulmonary emboli, heart failure. Yeah, all these could be part of it. And since they include so many things in the COPD, it now has made it the 5th leading cause of death worldwide. And estimated by 2020, it'll be the 3rd leading cause of death worldwide. Now, we do a lot of this stuff to ourselves by smoking. Guess it depends on what you're smoking, how fast you're gonna go, right? Cigarettes could get you quickly or could drag out for a long time. If you're smoking crack, you knew that was coming, didn't you? Yeah, smoking. Of course, Arkansas's got a question up over there passing marijuana for medicinal purposes. What do y'all think about that?
I think it's retarded.
I really don't care.
Oh, my head.
I think if you're gonna smoke pot, you're gonna smoke pot. I mean,
They just want to smoke it legally.
Pretty much.
But they say,
I don't really care.
I mean, I've even watched a couple commercials over there that so-and-so, my loved one was in so much pain and was able to get marijuana and felt no pain. Well, they felt nothing. That's what they
You
felt.
see the one about the soldiers or whatever?
No.
There's a commercial
It's for
saying that,
post-traumatic stress.
yeah, that the soldiers
I know.
shouldn't be denied
Yeah.
something
When I
further.
was in my speech class, somebody did a like a persuasive speech over marijuana and why it should be legal. And he said his dad had cancer and that he did smoke marijuana. He could just go out on the side of the street and buy some marijuana, and he'd smoke it maybe like once or twice a day to help him with like the.
Doesn't
chemo.
necessarily prolong life, but
No.
It
they're
helps the
saying-
symptoms
Helps
of
with the
the
symptoms.
they're
nausea.
saying that
Helps
you
with
have a better
nausea.
life during that time frame
Helps
because
you with eating and things
I
like
say
that.
if they
it
wanna get
nulls
it.
all forms of feeling after a while, and you really could care less about life if you smoke enough of it.
Yeah.
I'd rather them have a
It makes
safe
you
place
high.
to
It don't
get
really
it.
cover the pain.
It's a happy drug.
It don't really even cover the pain, it just makes you high.
It's a euphoria.
But I mean,
I don't think I've really met anyone that was like, if it was illegal, I would do it all the time. Either people do or don't.
I just think if it helps them, like extreme cancer cases, why not? And let them have some, clean place that they can get it.
Of course, I'm sure this question's based off a prescription drug.
Mhm.
Yeah, but
But aren't they taking the hallucinogenic part of it out of the medicine?
I'm not sure how they're adapting the drug.
My aunt's-
Being a
My aunt's been
prescription,
taking it for 30 years for her multiple sclerosis, and it's helped her a lot.
yeah, multiple sclerosis is a
She does it, you know,
horrible,
sit there
debilitating.
smoking joint after joint.
Yeah. I can see both sides, and I can see where abuse could certainly come from it, but abuse would be really pending upon the doctors, wouldn't it? Just
Yeah,
how
people-
liberal are they gonna prescribe this stuff?
People abuse the pain, like over the, they abuse.
Narcotics.
There's,
Yeah.
there's
All the
even a
time.
registry, a national registry, how many times they have gotten this drug, and somehow pharmacists and doctors don't pay attention to it a lot of the times. They keep prescribing stuff, and that's how it gets.
Well, even a veterinarian using certain kinds of narcotics on animals, they keep it under a lock. I mean, we're talking a safe lock. And they have to document the amount they use, the date they use it, what kind of animal they use it on. And they get randomly checked. And if somebody comes by and checks and that log does not match the amount that's in that bottle, and they're in a heap of trouble. So, you know, it's the same situation as this. You know, if it passes in Arkansas, the question will be here. It'll be here
I
in
don't
the next
think it'll
election.
pass
I
right
doubt it'll
now.
pass.
You don't
That's
think it'll
crazy.
pass?
Not yet, it's not, it's,
The
they're the
medical
first in the
industry is
South.
pretty much against it, is what I'm gathering.
Yeah.
Is that what y'all been
I
seeing
think
in
so,
ads and
too.
stuff? And I even saw where they had a debate over in Arkansas and had the medical industry here and the people that was the advocates over here, and the medical industry just, they've been against it. Of course, it's been legal in California since the 20s.
Yeah.
Well, at least they thought it was. They smoked so much, they really didn't know the law,
I believe
so.
it's legal now, well,
It
yeah, like,
is, it has been.
There's like
Yeah.
several states that.
And in Alaska, I think you can have like 3 plants.
Oh, you can have 3 plants of your own?
Yeah, I think so.
In most states that
I'm
it's
just getting
medical, they. you can
Cracked me
grow
up a few
them.
years ago. I went to, well, me and Mr. Hughes' science department, wrote a grant for a trip to Hawaii to study volcanoes. Went to the Big Island is where we went. It was a 7-day, it was a class to the University of Hawaii, and Dayton, Ohio, and the National Science Foundation all put this together. But anyway, we was lucky enough to go on it. And we stayed right on, in Hilo, and of course it's right on a freshwater stream that run into the ocean. The ocean just right there, and or anywhere you go in Hilo, no bigger than it was, you just walked. So we'd walk out of the motel and walk down the street to Uncle Bill's, which they don't have just restaurants, they're all basically pubs. You
Mhm.
drink all you want, eat all you want, and whatever. So we go to Uncle Bill's pub down there, which usually had fresh fish of the day or steak, or food was great. But to get there, people like to fish where the fresh water run into the salt water. There's people fishing there 24/7, just lined up down through there fishing. And you can get high just walking down that sidewalk. There's marijuana flowing up and down that stream, well, more than the stream was flowing, there's marijuana, and those people as happy as they could be. How you doing? Doing great, how are you? They was smoking marijuana, and the guy that was teaching the class got to talking about all the marijuana that gets grown back in some of these lava fields in the middle of nowhere, and nobody get to them, but they'll find them with helicopters and things like that. So there's people on this island don't do anything but grow marijuana. That's all they do, and they make a well of a living at it. So, but yeah, I don't know. That's interesting though. I don't know if there's ever been any studies done on long-term effects of the lungs with
Haven't,
marijuana.
that's why they're not sure of like how it affects you.
We know cigarettes obviously will, but what kind of carcinogens are in marijuana? It's another plant, just like tobacco's a plant. So, you know, not knowing those options is probably the biggest reason that the medical field's against it. Because you know, if we prescribe you that, and we give you another illness and it kills you faster than what you have, what kind of medical practice
Well, they
is
do
that?
that with prescription pills already.
All the time.
I mean, it's just.
It's an excellent point. You see a commercial on TV, this is gonna help your skin, but it's gonna give you 14 other diseases
in
to
the
help your
nursing
skin from
home,
itching.
We have to look
I
up
think
all
I'll
the.
itch.
We look
I
up
can
all
find
the
a place
drugs.
to scratch, see?
There's a lot of drugs that it.
We look up the drugs and like what it's for causes all this, so they take other drugs to help with this, but it's just, you know, they're taking so many to reverse the side effects of this
Yeah.
one, and
Some people's taken drugs so many years and they end up having to go to a different doctor, and this doctor says, we're just gonna take you off all these. Oh my gosh, you're killing me. And they're way better off than just getting off of them. And I mean, our grandparents didn't have all those drugs, our great-grandparents, and they learned to get along just fine, didn't they? Pills are answer. Take a pill and we're cured, right? Well, I thought that's some interesting stuff there on COPD, and it's interesting to see the issue coming up in Arkansas, how it turns out. And there are several states, I think it's actually legal in now. I'm not sure how many, but they stated over there, there's probably less than 10, but there are several states that it's legal in. Dalton's Law, over on 540, we gotta pick up the pace here. Total pressure of a gas mixture equals the sum of all the pressures of each gas in the mixture. So if we've got 10 gases, each individual gas will equal a certain amount. You tally them all up, we get 100%, right? So that's all it's saying. So, I mean, we could have come up with that and thrown our name in there. 9 o'clock physiology class is law. Yeah. The partial pressures of gases in the blood. Henry's law. This is fairly important because there's a little bit of thought, a little more thought in this one than in Dalton's law. When a liquid and a gas, such as blood and alveolar air, are at equilibrium, the amount of gas dissolved in the fluid reaches a maximum value. In other words, your blood's only going to carry so much oxygen. What determines this? This is Henry's law. These values depends on solubility of the gas in the fluid. This is how soluble is this gas. Number two, temperature of the fluid. Temperature is probably your biggest component here. Warmer temperature, less oxygen dissolved. Think about this. When you exercise, you need to utilize more oxygen, don't you? Where's your body temperature? Going up or going down when you exercise? Going up. Increased body temperature causes more oxygen to get out of the blood and into the tissue, so it makes you more efficient. So it's like if we're efficient, and there's a pool of water out here that's 90 degrees, there's a pool of water over here that's 60 degrees, which one's going to hold more oxygen? 60 degrees holds more oxygen. So if you're swimming in the summertime, you ever been out there, surface temperatures 90 degrees and your feet are dangling in some cold water? There's where your fish are, right about feet depth right there, because that's where your oxygen content is. Fish have spent a lot of time sucking out oxygen anyway. There's only 0.9% saturation oxygen in water anyway. So 20% of their energy is to breathe and 1% of ours is to breathe. So that's pretty significant to a fish. So Henry's law makes a lot of sense, and that temperature is definitely a big one, and the partial pressure of the gas. If it's a partial pressure of 1%, it's not going to get near as much saturation as oxygen would at 20%. See? So, but we have to watch nitrogen at 79% or 78 point something percent. 542, significance of blood PO2 and PCO2, pressure of O2, pressure of CO2. We work off negative feedback, would you agree? All right, so we're not going to function off chemoreceptors identifying oxygen in the blood flow system. We're going to key off CO2. If CO2 is up, where's oxygen? Down. CO2 down, oxygen should be negative feedback. 544. Pulmonary circulation and ventilation perfusion ratios. Here we have a low pressure, low resistance pathway. We've got to keep blood flowing through it. If for some reason we have left side of heart problems or failure, and blood does not keep going forward, but back drops into the right side and it'll back up into the lungs, and we'll have pulmonary edema, which that's where they'll write in the chart congestive heart failure, and literally they have pulmonary edema, but what's the problem? It lies in the left side of the heart, which is ultimately going to be the demise, so they put us abroad something in there. And immediate problem is this, what's caused it this, what's going to be ultimate demise? This, because it caused this, and that's going to shut down. When the lungs fill up, they can't breathe. So that's what it comes down to. Pulmonary edema occurs when there is pulmonary hypertension, which may be produced by left ventricular heart failure. So that's probably the most common. 545, oxygen toxicity. May develop rapidly when the pressure of O2 rises above 2.5 atmospheres. Can be damaging to the nervous system, even to the point of causing coma and death. We can have oxygen toxicity. If you go in the hospital and they put an oxygen mask on you, if they don't know what the sound inhaler they're doing, they can kill you with that oxygen mask. Because there's a little pressure gauge over there. The respiratory therapist, he'll mess with it. He might up it or down it for certain situations, but there's a realm he'll stay within. He knows the extreme of that realm. It can kill you. Most of the time, it's much easier if we use a dilution of a mixture of gases with oxygen being the main component in it, and that'll prevent the increased chances of oxygen toxicity. Nitrogen narcosis resembles alcohol intoxication. Some of y'all can associate to that, I'm sure. Depending on the depth of the diver may experience what Jacques Cousteau termed rapture of the deep. Now, does anybody even know who Jacques Cousteau is? All right.
French guy.
He's a French sailor that traveled the 7 seas many times. Now I think his son's doing it. Jacques Lillet. Look, I'm not sure he's even alive now. He may have even passed away, but he had TV shows on for a long time. Rapture of the deep. Dizziness and extreme drowsiness and other narcotizing effects. Decompression sickness. If decompression occurs too rapidly, bubbles of nitrogen can form in the tissue fluids and enter the blood. This actually is very painful, but could kill you if that bubble would be no different than a blood clot sticking somewhere in a vessel. So it could kill you as well, but commonly known as the bends because it causes so much pain by stopping up different vessels throughout the body. Then primary treatment for decompression is hyperbaric oxygen treatment. Airplanes that fly long distances at high altitude have the same problem with pressurized cabins. If they become depressurized, you would be set up in the same situation. So whether you're diving deep or you're way up in the air, both of them can create the same problem. Moving on over to brain stem and respiratory centers. What part of the brain you think takes care of the rhythmicity center? Medulla. They have I neurons and E neurons. I like the simplicity of this. I would be for inspiration and E would be for expiration. Isn't that nice to know? And that creates the breathing patterns that we have for 14 to 16 breaths a minute. Now they go ahead and relist. The apneustic center appears to promote inspiration, and pneumotaxic center seems to antagonize the apneustic. Now if we promote inspiration, why do we want to antagonize that? So we can
Be inspired.
expire. We're already inspired. We need to stop it so we can expire. If all we do is inspire, then we're going to blow up. No other choice. So we inspire for a while and we inhibit that, and that allows us to expire. That sequential event causes 14 to 16 breaths a minute. The chemoreceptors are we have central chemoreceptors in the medulla and peripheral chemoreceptors out in the carotid and aortic bodies. The central chemoreceptors can only see carbon dioxide. The medulla can only detect carbon dioxide. The peripheral can detect hydrogen. Ultimately coming back is information to the medulla which adjusts the rhythmicity center of breathing up or down where we need it to be. But these chemoreceptors are extremely important. Reading the negative, which was CO2 and hydrogen. Increase hydrogen, low O2. Increase CO2, low O2. They were reading the negative, and we know what we need to do is write the opposite of what we have. All right, effects of blood pressure, CO2, and pH on ventilation. Here it is in short. Blood pressure of CO2, increased CO2, we're going to increase ventilation to get rid of it. Make sense? Too much CO2, how do we get rid of it? We breathe more, breathe faster. So hyperventilation would do that. pH, increased pH is also, if pH increases, that means CO2 has also increased because increased CO2 causes increase in pH. And let me reestablish this. Let's do this. Let's do acidic pH. They use increase, decrease in the book. Acidic pH, on the pH scale, it's actually a decrease in pH, right? Acidic pH is equal to an increase of CO2. Increased CO2 is going to cause acidity in the bloodstream. So that's the equivalent. That's going to increase respiratory rate to breathe off extra CO2. So pressure of CO2 and pH are direct correlations. Either one's going to increase ventilation. The equation on 548 helps explain quite a bit of this. In this equation, CO2 plus H2O yields carbonic acid, which yields hydrogen and bicarbonate. It creates a buffer at the end to help buffer the acid that's already been created. And this actually, you could flip those arrows around. This is actually a reversible reaction. In chemistry, what do they call that? What do they call reversible reactions? Double what? Too far gone on chemistry. Say that again? It's got a fancy name or something, I don't know. Okay, hypoventilation causes a rise in CO2. Hypoventilation, not breathing much, causes a rise in CO2, which would cause hypercapnia. To fix hypercapnia, you'd want to increase ventilation, right? Conversely, resulting in hypocapnia. So hypo is not much, hyper is too much. You do right the opposite to fix it. Chemoreceptors in the medulla, we've already talked about those. So again, we're seeing CO2 is what we're seeing. It mentions cause 8 hydrogen in there, but hydrogen's based off of peripheral receptors and not central receptors in the medulla. All right, a lot of this starts becoming repetitive here. So let's start right there. What we have a lab on Tuesday, correct? And we're starting presentations Tuesday. I'm probably going to take the first few minutes of since presentations we're a small group, and we're doing that in 2 different labs. I'll probably take part of the lab and try to get some more lecture done here, and we'll do presentations. So we didn't quite get finished. We still liked a few pages, like forever.
Are you missing this?
So we'll do that.
Probably will.